Good afternoon and good morning to you if you are on the West Coast. It's such a great pleasure to introduce this training activity, Association of Health Literacy with Poor Diabetes Outcomes. My name is Jose Leon. I am the Chief Medical Officer for the National Center for Health and Public Housing, and I am very pleased to have a great speaker who is going to lead the conversation on health literacy and diabetes outcomes. So before we get started, I'm just going to give some background information about the National Center for Health and Public Housing. The National Center for Health and Public Housing is funded by HRSA to provide training and technical assistance to community health centers located in or immediately accessible to public housing. And the mission of the National Center is to strengthen the capacity of public housing primary care grantees as well as other health center programs by providing training and a range of technical assistance. This session is a live session. We all at this moment, all lines are muted. If you have any questions at the end, we are going to provide a few minutes. You can either chat, you can either use the chat box and type your question, or you can click on your raise hand icon and your line will be unmuted. I encourage you to provide feedback and any best practice or anything that you are doing to help your patients. This is a very interesting topic and very important topic. And as you know, by working with all these underserved communities, you know, the challenge to provide or to follow the recommendations from the clinicians. So I encourage you to really participate in this activity and provide your feedback and your questions and your comments. There are 356 health center programs located in or immediately accessible to public housing. In 2018, they served over 4 million patients. There are 107 public housing primary care grantees, and in 2018, according to UDS, they provided health services to over 800,000 patients. This is some information about the demographics of those living in public housing. The most recent information from HUD is that there are around 2 million residents living in public housing and probably an average of 2.2 people per household. 59% of these are female and 55% of them less than high school diploma. This is another this is good information, you know, because as you can see, if you link probably high school or education and health literacy, this is a population that needs to receive additional information on all the medications and all the instructions especially for those with diabetes. And over 83% of them are at or below the poverty line. In 2018, again, and this is taken from UDS, 32% of health center patients had poorly controlled A1C, and 9% of those public housing primary care grantee patients had diabetes. According to a HUD document, Health Picture of HUD-assisted adults, over 33% of them, of the diabetic patients, have uncontrolled diabetes. This information is just to provide the diabetes percentage in HUD-assisted programs, including public housing and Section 8 or vouchers, and around 18% of those receiving assistance from HUD have diabetes. So this is how you can help your patients, and one of the bullet points here is, in addition to create care teams and using care coordinators, is to screen for SDOH needs, such as health literacy. And then I'm going to introduce Teresita Lawson. Teresita Lawson is a bilingual bicultural registered pharmacist licensed in New Jersey. Her role as clinical pharmacist for Sioux Falls Health Center included implementation of continued quality improvement initiatives for the clinical pharmacy services program at Sioux Falls Health Center. Her dedication to patient-centered care prompted the organization to designate her as the organization's PCMH project coordinator in charge of spearheading NCQA recognition for Sioux Falls Health Center. She earned her Bachelor's of Science in Pharmacy at Arnold and Mary Schwartz College of Pharmacy of Long Island University and earned her board certification in diabetes education in 2011. Having practiced in the retail pharmacy arena since 1989, Teresita has extensive experience in patient counseling and medication therapy management. Her role in Sioux Falls Health Center has centered around direct patient care, patient education, and lifestyle modifications and adherence monitoring, identification of potential medication-related problems and adverse events, and provided education as well as medication therapy management. Teresita joined the FDU School of Pharmacy in January 2016 as an adjunct professor, where she engaged in teaching Spanish for the pharmacy professionals. In July 2016, she was appointed clinical assistant professor of pharmacy practice. She has since retired from academia and is now actively consulting in the pharmaceutical industry and volunteered her time in helping to educate patients with diabetes live productive and full lives by overcoming barriers to care. So without further ado, I will turn it over to Teresita.
Hello, everyone. It's such a pleasure to be here, and I'm thrilled to be able to share the model that I practiced under, hoping that it'll help others improve their programs. And here we go. I come, as Dr. Leon said, from the federally qualified health center arena. I worked for Sioux Falls Health Center between 2008 and 2016. I was charged with the design and implementation and continuous quality improvement of the clinical services program within Sioux Falls, along with Chief Medical Officer Dr. Rena Ramirez. It was established as a result of the Patient Safety and Clinical Pharmacy Services Collaborative from HRSA, and it did focus on a team-based approach that was very much interdisciplinary. And we aimed at improving our patient care and always keeping the patient at the center of it all. And we aimed to improve their outcomes, and we also tried very hard to expand the clinical pharmacy services program, as it just started with just me hanging out in the hallway for the first year or so. It was a collaborative, and it was based on the coordinated care of patients, and they all had difficult to control diabetes. They were all high risk, greater than 9% A1C, more than 5 medications, and they all had comorbidities associated with the diabetes. The program, as a result of its success, was selected to participate in Project Impact Diabetes. We were one of 25 communities selected, and it was an AFA Foundation initiative, and it was funded by the Bristol Myers Squibb Foundation. And it was earned several awards, including the BD Direct Relief Innovation and Diabetes Care Award and the New Jersey Affiliation for Family Practice Patient-Centered Innovation Award. So here are some facts about health literacy, which I'm sure you all are very much aware of. These come from the Quick Guide to Health Literacy from the United States Department of Health and Human Services. It's not surprising that only 12% of adults have proficient health literacy, according to the assessment. 9 out of 10 adults may lack the skills needed to manage their health. 14% of adults, about 30 million people, have below basic health literacy. And they are more likely to report their health as poor, which is not very surprising. And they likely lack resources such as very important health insurance. These attributes about health literacy have been linked to poor health outcomes, higher rates of hospitalizations, less frequent use of preventive services, and of course, higher healthcare costs. These populations are more likely to experience low health literacy, such as older adults, our seniors. Racial and ethnic minorities are also more tied to lower health literacy levels. People with less than a high school degree or GED, low income levels, non-native speakers of English, and people that have compromised health status. Basically, if they have less education, they have a language barrier, they have cultural barriers that may be associated with their condition, they have less access to resources, and age is also an impact. The older that we get, unfortunately, the more challenged we become with the number of medications that we have to take. That makes it more difficult to navigate the system, and it does have a negative effect on their health literacy levels. They're more likely to skip preventive measures like vaccines, mammograms, pap smears. They enter the system later, which means that they're much sicker, so it's more challenging to help them come to goal. They're more likely to have multiple chronic conditions and comorbidities. They're associated with preventable hospital visits that we could have prevented had they entered the system earlier. And they're absolutely more apt at increasing the rates of hospitalizations and the use of our emergency services. And it definitely does have a negative psychological effect on our patients. They feel shame, they feel the inability to approach us, and that is a definitive barrier to care for them. So how do we improve the outcomes in our patients? I can share what we did at Zufall and the model that I practiced under, and it worked very well for us. It started, as I said, from the Patient Safety and Pharmacy Collaborative with HRSA, which has now graduated to the AIM Collaborative. It had 10 components in it. It was very, very comprehensive, and it always kept the patient at the center of care. We did embed the pharmacist patient care process, which is the pharmacist guideline for care and medication management. We embedded the evidence-based American Association of Diabetes Education 7 self-care behaviors as part of our patient education curriculum. Again, it was a comprehensive 10-element program. We had a very, very high touch culture with our patients. I would meet with them multiple times in a week if I had to, if not every week, until they reached goal and they were out of danger. It was very interdisciplinary, very robust, with conversations going back and forth, either through the EMR or face to face, in consulting with the providers and helping the patients remediate their regimens if need be. We also made sure that the program made available the preventive services and recommendations to our patients regarding vaccines and referrals to specialists if need be. We did concentrate and track our ER visits and hospitalizations through care transitions, and we followed up with those patients if need be and reviewed their medications whenever they got out of the hospital or visited the ER. All encounters were documented in the electronic medical record. Everybody was on the same page with respect to the patient, and it was most definitely aligned with the NCQA efforts to recognize Zufall Health Center as a patient-centered medical home. This was our delivery model, and basically the pharmacy program was embedded within the QI initiatives within the health center. So it all started with provider referral of a high-risk patient. I would engage enabling services like behavioral health, PCMH coordinators, even medical assistants if I had to. It would all be reported to the chief medical officer on our monthly QI meetings, where I would report potential adverse drug events and adverse drug events if they occurred. Patient follow-up was a regular, an integral piece of the model. So health literacy, as we all know, it affects cost. Uh, if the patient doesn't have insurance, if they're low income, if they're underinsured, cost is going to become a very, very big impact for health literacy in the patient. Access becomes a problem. They're less likely to access the system until it's too late. Adherence is definitely an issue with these patients. If they don't understand what's in it for them, what the medication is doing, what side effects to expect, they're less likely to take the medication. And clinical inertia also plays a piece in this role with health literacy, because if you have a complicated regimen, you're always going to think about, is the patient ready? Can the patient inject insulin? Will they understand why we have to add another agent to their regimen? And obviously, if they have low health literacy, they're less likely to know about the resources out there to help them. And the patient care process here, I put this here because that's the guideline that I practice under, and it works very well. We all have to be objective. We all have to collect data. We all have to assess and plan, and we have to put that plan into action, hopefully in an interdisciplinary fashion, and we always, always have to follow up and monitor. So what are the barriers to improving their outcomes? Well, medication side effects is up there, right? Because hypoglycemia is one of the biggest fears we have with our patients. And of course, they don't want to gain weight. Nobody wants to gain weight. And a lot of the medications that we use, unfortunately, do have that side effect, insulin being one of them. Regimens that require familiarization with new methods of administration and dosing may pose a big barrier for a lot of our patients, especially those that are greater than 9%. And hey, we need to put them on insulin. We need to put them on a GLP-1. And how are we going to do that? The cost, as I mentioned before, if they're underinsured, if they're low insured, they're less likely to access those medications. Health literacy, if they don't understand what's going on, that's going to pose an issue because they might be in denial. They might be resistant to change. So that level of health literacy is extremely important. So we always have to focus on educating our patients. Their health beliefs, they may come from culture. A lot of our patients believe that if they went on insulin, they were dying, they were failing. That feeling of failure is something that as providers of care, we need to overcome that and undermine that belief and make them aware that insulin is not going to hurt them, it's going to save their lives and prevent the consequences of diabetes. Fear is always an issue. If we get diagnosed with a chronic, lifelong disease, who wouldn't be scared? So that fear is really very integrated into the care of that patient. And then lastly, but very important, is the patient will get frustrated if they can't meet their goals. They don't understand why they're not meeting their goals. And that's where we could really make a positive impact in their lives. Some system barriers to medication adherence. Misinterpretation of prescription labels is something that we all know about. Take a simple one, for example, is take with food. So what does that mean? Does it mean that we take it before food? Do we take it with the first bite of food? Do we take it when we're in the middle of the meal or after food? So it really can be misinterpreted by the patient, and they are misinterpreted. Many studies have been made on this. Medication information is given in high literacy levels and in a multitude of papers. If you go to a pharmacy today and you pick up a prescription, you get a bag with stapled pieces of paper that look like a presentation that you're trying to give and you're studying. before you give it. So most people just take it and throw it in the vertical file. Patients feel very intimidated by that information. They also feel embarrassed to approach a professional and ask, hey, what does this mean? The lack of insurance or underinsured also poses a problem in a pharmacy, and how the care is given, how the counseling is given. The retail model, unfortunately, is inundated with time constraints, just as primary health care is. Our providers, our pharmacists are constantly being uh, turned into time. We have another patient, there's another prescription to fill. There's a lack of time to really have that valuable face encounter with the patient, to identify their barriers, identify their worries, address their concerns. And that is a really huge gap, in my opinion, in educating that patient and bringing them to care the way that we should be. So what works? We need to tap into the community that we are practicing in. We had a wonderful organization in our environment. They were called Hispanic Affairs, and they really did a lot of work with our Hispanic community and helped them to give them resources, make them aware of the help that is within the community, and they worked closely with the health center to help our patients. Include the family if you can. That engagement of the family is invaluable, as I will tell you in a patient story that's coming up. Investigate the medication access in your community. Many of our pharmacies were giving discount programs, free antibiotics, for example, which I'm not really too much in agreement there, but when it was needed, it was needed. Needy Meds, an online resource that most of you probably know about, but is very valuable in finding manufacturer coupons. Our RX Outreach is another one that I used a lot for our diabetic patients. Always assess what your patient understands about their medications. Use tools like the Teach Back method. Understand what their level of health literacy is and what cultural barriers might be present in your community and population. Use tools that are third grade level or less. Do not overestimate your patient's knowledge. And use evidence-based practices like motivational interviewing and the patient care process to tap into what's important to them. What will motivate them to make that change and move into that next step? Shared decision-making tools, invaluable. They are very appropriate, and they help the provider move through and get the patient through acceptance for their medication. Frequent follow-up and high touch if possible. If you have the ability to do that, that is always going to be the number one thing that's going to help you stay on top of a patient that is extremely high risk and in danger of ending up in a hospital. Collaborative teamwork, interdisciplinary care is the way to go. I'm sure this is not new to any of you, but if you could continue the staff training and engage your staff in participating in the program, that is invaluable too. If you can bring a pharmacist on board, it's always the expense of the pharmacist that is of concern to a lot of practices, but there is a lot of studies out there regarding pharmacists in primary care, and I can tell you from my background and my experience, it is worth every penny of the expense. And even if you brought in a pharmacist for 4 hours a week to evaluate your most high-risk patients, you would benefit in the end with improved patient outcomes. And a certified diabetes educator, if you could get both in one package, you can't lose. This is one of my favorite tools that I wanted to share with you. This was a tool that me and Dr. Ramirez worked upon together. It was a collaborative effort. Very simple tool, but it served us in the Teach Back method. It served as a personal medication list for the patient, an action plan. it helped us evaluate how high their health literacy was by engaging them in the conversation, and it also helped them as a self-management tool. This was brought in with the Brown Bag Initiative, which is how the program started in the beginning, just as a simple brown bag. So how did we use this tool? I used the simple method, which is really just simplify the regimen, impart knowledge, modify their beliefs, provide communication, leave your bias behind, and evaluate their adherence. So it really did help improve their adherence, because once the patient understood what was going on with their medications and what they were for, it really did unveil that barrier. It addresses issues like cognition. Many patients were forgetting their doses, especially in our elderly group. It helps us identify solutions for them that they can be part of the solution as well. And it helps us mitigate literacy issues. Like, for example, someone may not be able to read, but they might be able to read a clock, or they might be able to identify that when the sun rises, that means morning. So all of these aspects of the tool really helped engage the patient and reduce their side effects and enhance their acceptance of the regimen. It also aligned with our QI initiatives with respect to medication reconciliation and meaningful use, as well as PCMH. But more importantly, it was a take-home tool for the patient. So here I'm presenting a gentleman. He was 49 years old, a Hispanic male. He did speak English, but it was pretty much limited. He had diabetes for 3 years, hypertension, and hyperlipidemia. My first encounter with him, his blood pressure was a little out of control, not in range. He brought his brown bag in. It had metformin, 1,000 milligrams BID, hydrochlorothiazide, 25 milligrams daily, and a daily aspirin. When I asked open-ended questions pointing to the metformin, I assessed how the patient, what did the patient know about the medication? Did he know that it was for diabetes? He did, but he hated taking that medication. He hated the fact that it caused really bad diarrhea. He felt uncomfortable with his stomach. He had pain. So he tended not to take it, but the interview also disclosed that he was taking the metformin on an empty stomach. He was only separating the dose by 3 hours at most, taking it in the morning and at lunchtime. He was also taking the diuretic at night, and he was having to get up on a frequent basis. And it revealed that his bottle really didn't contain the amount of pills that it should have for the time that he had filled it. It contained way more. So that revealed non-adherence as well. So the patient really wasn't very, very happy, and obviously he was out of goal, not at goal with his diabetes. So what did we do? I consulted with the doctor. I advised that perhaps, the patient didn't have prior history of heart disease as of yet. Did he really need the aspirin? And the hydrochlorothiazide really isn't the first go-to drug for high blood pressure in diabetes. You want to give them an ACE or an ARB, help protect their kidneys, and perhaps going from the immediate release metformin to the extended release metformin would relieve some of the GI side effects associated with the drug. I also imparted that knowledge to the patient and helped him understand that at the very least he should be taking the metformin with food and separating it by at least 8 hours in order to minimize his side effects. And I also discussed the fact that he should uh, follow up with me at least every 2 weeks until we got him to goal. I empathized with the patient. I always treated them with the highest respect because they are the most important member of the care team. That's the patient. And the tool also helped evaluate his adherence to the medication regimen. After multiple visits with the gentleman, He reported that he was very happy with the ACE, no longer having to get up every 10 minutes during the night with the hydrochlorothiazide. The metformin was no longer causing side effects, and he was at goal with his diabetes and his hypertension. This is one adherence assessment tool that a gentleman by the name of Dr. David Marrero shared with me in a 2014 ADA conference. He was from the University of Indiana. His tool is much more extensive than this, but the idea came from his tool. How can we measure the patient's desire to follow a medication regimen? I highly recommend that some form of drug adherence risk assessment tool is embedded within your electronic medical records so that every member of the care team is aware of how much of a potential risk that the patient may be facing in order for us to address it. It's very simple. It was conducted on all our patients. It helped identify their barriers. It helped identify the potential for non-adherence to give us time to address it. And it was embedded in every single encounter with my patients. Back in 2008, the Institute of Medicine identified a universal medication label, and you see it here pictured. As you could see on the right-hand side, you have your typical label, 2 capsules by mouth twice daily. You have the name of the medication, the refills, how many again, who prescribed it. On the left-hand side, you have a very bold first line. That's the name of the medication. That's the strength you're taking. And they no longer use terms like once daily, twice daily, 4 times a day. They actually specify the dosing as 2 pills in the morning, 2 pills in the evening. This is a great, awesome idea if we could spread it across the nation. Unfortunately, it hasn't really been able to gain ground on a national level. So as we all know, the prescription label is an issue with our patients. And at Zufel Health Center, we designed this handout for our patients. We also educated our staff on providing this handout to every single patient at every single encounter. And it really did help. In addition to that, we also took them to our community pharmacies and had them handed out to our patients. This was an effort to educate patients on what's important on a prescription label. Make sure your name is on that label. Make sure that prescription is for you. It educates them on refills. How often? When does the medication expire? It helps them navigate the system, and it empowers the patient to become engaged in their own treatment. And it also engages your community partners. And it was an awesome tool. I'm not sure if they're still using it. I'm sure they are if I know them. Also, another important tool that I found very, very valuable was the education on a nutritional label. This helped gauge the patient's numeracy abilities. Were they able to understand what the serving size is? What's a good amount of sugar amount? What's a good protein? What's a bad protein? What's saturated fat, what's unsaturated fat. So it really did avail a lot of opportunities to educate the patient on nutrition and help them get on the pathway to healthier eating habits. We also embedded, as I mentioned before, the AADE 7 self-care behaviors in our practice. Basically, we embedded them into the electronic medical record. We utilized them at every encounter. It was a guided encounter through motivational interviewing, which allowed us to set goals together with our patients. And that word together is integral because a patient will not do what they don't want to do. But if they want to do it, that's a totally different story. That's a totally different starter. and it assesses their goals and their targets. Is it realistic? Are we going from losing 10 pounds to 100 pounds in 2 weeks? Obviously, the latter being completely unrealistic. And it helps us assess their behaviors. This is an example of what the AADE7 self-care behaviors look like and the documentation in the EMR, what the EMR really allowed us to do. And it had the ruler method embedded in it. As you could see, how important is it to you? It was a 9. This patient in particular had cut out all her carbs from her diet, and it wasn't really improving her sugars at all. She thought that she could take less insulin, take less metformin, and as a result, her A1C was increasing. And every aspect of this modification tool, patient modification tool, was embedded in every encounter, so it helped us guide the patient through change. Every patient got a Where Do I Begin booklet, especially if they were newly diagnosed. But I also reviewed this booklet with those that weren't newly diagnosed and couldn't reach target. I was always trying to figure out, why is this patient not reaching goal? What is their barrier? The booklet is awesome. It's available in both English and Spanish. It is a free publication from the ADA. It includes the plate method. It includes advice on medications, monitoring, prevention, physical activity. So everyone got it. In addition to that, Zufall, we developed this handout that you see here with the plate method. It was called the 5210. It addressed screen time with the patient, how much time they spend on physical activity, and what a plate should look like. So everybody was handing this handout out. It was not just the clinical pharmacy program that did it. It was organization wide, just as the How to Read a Prescription Label was. Here's my lady from Senegal, Africa. She was an immigrant to the United States. She was a 57-year-old woman, absolutely no English whatsoever, and she lived with her daughter and son-in-law. She was newly diagnosed in August of 2011, where her first visit, her A1C was greater than 14%. In fact, the machine couldn't even read it. She had your classic diabetes symptoms. Uh, the emergency room had only put her on a sulfonylurea. She was very, very scared. On a level from 1 to 10, she was a 1 on health literacy. And in her culture, her women were mostly dependent and not self-reliant. I engaged her family. Um, the knowledge assessment that came as a result of her son-in-law being the interpreter was integral to her well-being and her moving forward in her care. The education was based on that assessment. I educated her on the pathology of diabetes in a simple way, of course. I had a little diagram that I would do with metformin and what it's doing for you, type of thing. And I addressed the insulin resistance at that point. And I also addressed the nutrition, because one of the issues that really scared this nice lady was the fact that she was so scared that she wasn't able to eat the foods that her culture was used to. She thought she had to change her entire life program, and she was so pleased to find out that, hey, no, you can eat what you are used to eating, as long as you learn how to eat it in a balance and in the right proportion, you'll be doing just fine. We adjusted her medications, obviously. We put her on metformin, multiple back and forths with provider consultations. We had her on basal insulin and metformin. We tracked adverse drug events, anything that may go wrong. We referred her to the 340B program, which availed her of the insulin at a much, much reduced level. Her A1C, as a result, in February of 2011, her A1C came down to 7.6. And later on, in May of 2013, her A1C came down to 6.2. So what worked for us? In my opinion, the biggest thing that's very, very important is coordination and collaborative care. We have to take the patient as a whole and never, ever, ever put in our bias. We always have to incite trust, be empathetic to their situation. We should use evidence-based tools, but by all means, within those evidence-based practices, put in your own innovation, put in your own ideas of what you think will work with your population, and keep it simple. It doesn't need to be complicated. High touch, very, very important, especially with your high risk patients, especially with those that are in the deepest denial that they can be. Those are the individuals that need the higher touch. Patient education, patient education. I can't say it any better than that. When you simply explain what's going on, what can they do to make a difference, that is a very, very powerful, powerful tool to use with your patients. Medication management, that's at the top of the list, folks. That's where people fall through the cracks. One of the measures in retail pharmacy is a percent days filled or covered. I always use the analogy for one of my patients that had all of his prescription bottles ready for me to evaluate with his brown bag, but he wasn't taking any of them. He was picking them up from the pharmacy, but he wasn't taking them. So that measure is really not tied to a patient outcome. I would really love to see that model graduate to being tied more to the patient outcome instead of to how many pills have been filled during a certain amount of time. Self-management education, another one. Use evidence-based methods, the ADA, the AADE, use the PSPC, embed medication management. Cultural sensitivity, extremely important, should be front and center in every encounter, no matter what. Patient partnering, make sure that you give them that eye contact, that smile, that welcoming feeling that they are safe, they can trust you, and that will open up the door to helping them overcome their barriers, address their health beliefs, and enhance their care to treatment. So my hope and Dr. Leon's hope is that we all get together in April to help us overcome our challenges in improving those outcomes in our patients with low health literacy. And what I would really love to ask of you is to share your stories, share your lessons learned. What hurdles have you been able to overcome? What have you not been able to overcome? What are your most difficult challenges? What methods and tools have you come up with? And then we'd like to put them all together into a learning session where we could all learn from and help our patients as much as we can. You can send your stories, your ideas, your quality improvements that have worked, that haven't worked, whatever it is that you might think will be valuable to share for all to learn from. You could share them with Dr. Leon at jose.leon@namgt.com or to myself at tlaw4312@gmail.com. And there's my phone number, 973-534-2241. Please feel free to call at any time, reach out to me at any time. We're here to help and to contribute to the efforts to improving our patient outcomes and helping this situation move forward to a better life. Thank you all, and it's been a real pleasure.
Thank you, Teresita. Thank you for this great presentation. I'd like to thank you again for putting together all the information, the case studies, and the information on cultural competency, health literacy, and medication management. we would like to hear from the audience any questions, any comments, anything related to emerging practices or best practices that they may have in place, any challenges. You can either type your question or your comment, or you can also provide us information by unmuting your line. So again, if you would like to ask a question to Teresita, just make sure that either you submit your questions through your through your box, or if you if you have called, just use your raise hand icon and your line will be unmuted. Any questions in the queue or any comments?
No, not yet, Dr. Now.
If there is a member of the quality group who would like to chime in on the presentation and share the best practice, anything, you know, you are free to do it.
You know, one of the things that I think would be most valuable is for people to share their tools, talk about what barriers they have come across if I didn't touch upon them, what issues might help them improve their delivery of care to patients that have low health literacy. That would be most helpful to everyone in the audience, I believe. Don't you think, Dr. Leon?
That's exactly right. And again, I mean, if they have anything to share, and there is no right now, I mean, they don't have an opportunity to do it right now, they can email me anything, any best practices or challenges. Email jose.leon@namgt.com. And in the meantime, to see whether we receive any other, we receive any questions, just want to provide some information about our next great national event. We are hosting the Public Housing Primary Care Conference June 18th to the 19th. This is going to take place in Alexandria, Virginia. You can visit our website, www.nchph.org, and you will find information on how to register or how to submit abstracts. You can also go to our website and find information about the resources and services that we provide, information on senior programs, funding opportunity announcements, and any HRSA updates. You will find information on past and upcoming webinars, information on our next or upcoming publications, interactive maps showing social determinants of health affecting public housing residents, information on HUD initiatives such as the smoke-free public housing, training manuals, information on the symposium, newsletters, or information on how to get one-on-one training. This is our contact information. If you would like to contact us, again, my email address is jose.leon@namgt.com. And I just need to check one more time if we have any additional questions.
Not at the moment, Dr. Now.
All right, thank you so much. One more thing. Please complete the post survey after the webinar is over. Your information is very valuable, so we can improve all the activities, all the training activities that we provide. And in advance, thank you so much to provide that information. And Teresita, I have a question in regards to health literacy. So it's one of the challenges that I've seen when I have conversation with the health centers is to provide resources in other languages, for instance, and to find the right resources. So in your experience, when it comes to to diabetes, in addition to the American Diabetes Association site where they can find free resources, is there any other organization or site that you recommend where health centers can download the resources for the patients, that are valuable for those who have uncontrolled diabetes?
Well, I think that their best bet, other than the ADA online resource, their best bet would be to tap into what is available in the community. Because if they go out into their community and find out what organizations are involved in the culture within their community, that would be the best advice that I could give them based on my experience with my population, is reach out to those organizations, because those organizations are the ones that are going to partner with you in giving, for example, cooking classes. We used to give cooking classes in association with the Hispanic Affairs in our community and help our Hispanic population understand that they can still enjoy their foods and eat healthy at the same time and live quality lives with diabetes. So that would be my advice. I am not aware of a direct website that's available out there other than the ADA. I use the ADA a lot because they do have programs on their website that are available in Spanish. So that's the one program that I would advise, but also to reach out into the community and partner with those organizations that are tapped into the culture of that community.
Excellent. Thank you so much, Teresita. Fide, any questions?
No.
No, at this moment. Well, again, if you have any comments, if you would like to share best practices, challenges, what has worked, what hasn't worked, make sure that you can contact us. Again, this is our contact information, or you can contact Teresita Lawson directly. These slides will be provided to all those who are participating today, in addition to other resources. So you will find Teresita's contact information. Otherwise, you can also contact any of the staff members here at the National Center for Healthy Public Housing, and we will be able to help you or send your questions to Teresita Lawson. Once again, thank you so much for attending this activity, and have a great afternoon. Thank you. Thank you, Teresita.
Thank you.